Hello and welcome to this 42nd episode in my series titled Questioning Woke Psychotherapy. My name is Michael Dwan Herrick. I'm a psychotherapist and life coach in private practice in London. In this episode, I'll talk about the difference between conversion therapy and exploratory therapy in the context of gender questioning children and young people. I'll also talk about this in the context of what has been called gender-affirming care. I've been thinking about this for a long time, but I'm now prompted to talk about it in the wake of the recent release of the CAS review on April 10th, as well as the United Kingdom Council for Psychotherapy, or UKCP, recently withdrawing its signature of agreement from the Memorandum of Understanding, MoU. I assume that most of you who are interested in this channel and who live in the UK will be aware of the CAS review, and some may also be aware of the MoU. For those of you who live in the US or elsewhere, you may not be aware of either. In preparing for this video, I initially attempted to write a substantial explanation of each, but have decided to give only very brief descriptions, relatively brief. My main interest is in talking about the difference between conversion and exploratory therapies. These recent developments are just the current context prompting me to speak up. The CAS review itself is a nearly 400-page document, so it's difficult to summarize briefly. The MoU is much easier to explain, so let me say just a little bit about each one, and then I'll move on to my main topic. The CAS review, also called the Independent Review of Gender Identity Services for Children and Young People, was commissioned in 2020 by NHS England and NHS Improvement and led by Dr. Hilary Cass, who's a retired consultant pediatrician and former president of the Royal College of Pediatrics and Child Health. The review examines gender services for children and young people, including those with gender dysphoria and those identifying as transgender. Dr. Cass published her interim report in March 2022, and the final report was just published on April 10th. Her report says that the clinical approach used by the Gender Identity Development Services, or GIDS, in the UK has not been subjected to some of the usual control measures typically applied with new treatments. She raised concerns about the lack of data collection by GIDS. While GIDS initially followed the Dutch protocol, the interim review said there were significant differences in the current NHS approach. Children with comorbidities did not receive adequate psychological support. Endocrinologists administering puberty blockers did not attend multidisciplinary meetings, nor did the frequency of meetings increase when adolescents received puberty blockers, all of which the Dutch approach recommends. The interim report further stated that GPs and other non-GIDS staff felt, quote, under pressure to adopt an unquestioning affirmative approach, unquote, to children unsure of their gender, overshadowing other issues such as poor mental health. The final report of the CAS review includes several systematic reviews of scientific literature carried out by University of York, encompassing the patient cohort, service pathways, international guidelines, social transitioning, puberty blockers, and hormone treatments. The CAS review makes a total of 32 recommendations based on its findings. I won't list them all, but here are a few. Social gender transition. The CAS report positions social transition as an active healthcare intervention, quote, because it may have significant effects on the child or young person in terms of their psychological functioning and longer-term outcomes, unquote. For young children, the review strongly discourages social transition, noting that sex of rearing may profoundly alter a child's developmental trajectory with long-ranging consequences. Puberty blockers. The use of puberty blockers to stop normally timed puberty will no longer be offered as part of England's publicly funded healthcare system. The problems with using puberty blockers for gender dysphoria were already part of the interim CAS report. and the NHSE had updated its puberty blocker policy a month before the issuing of the final CAS report. The CAS report identifies several reasons for caution around puberty blockers. They range from unclear treatment aims, other than altering a child's body, and a lack of credible evidence that stopping normally timed puberty leads to improvements in mental health, to safety concerns, for instance, bone health, and profound unknowns across a range of health domains, especially brain development. Also, the fact that nearly 100% of puberty-blocked youth proceed with cross-sex hormones was treated as a negative signal that puberty blockers may be setting children on an irreversible path of gender transition. Cross-sex hormones. The option to provide masculinizing or feminizing hormones from age 16 is available, but the review recommends extreme caution. There should be a clear clinical rationale for providing hormones at this stage rather than waiting until an individual reaches 18. Dr. Cass states, quote, "The new providers should be extremely cautious when considering whether to refer young people under 18 years for consideration of hormone intervention. To support this recommendation, while the new cross-sex hormones policy is being developed, NHSE has established a national multidisciplinary team that will review and need to agree on all recommendations for hormone intervention. Basically, the review found that benefits from cross-sex hormone treatment have been minimal and temporary. Change in the delivery care model overall. In addition to making recommendations about social transition and hormone interventions, the review challenged the concept that gender dysphoria, gender incongruence in youth is an exceptional condition that needs exceptional treatments delivered by exceptional models of care exemplified by gender clinics. It advises that the healthcare delivery system for gender dysphoric youth should be restructured in alignment with the way care is typically organized in England. The review also recognizes that the mental health challenges of Gen Z are likely at the root of the current dramatic increase in trans-identifying youth and acknowledges that detransitioning is a growing phenomena that cannot be ignored. As I said, the CAS review is long and packed with information. I've just provided some of the highlights, but I hope enough to give a sense of its concerns and its recommendations. Now I want to talk about the Memorandum of Understanding, or MoU. This is an agreement that was drawn up and signed initially in 2015 by all major regulatory and accrediting bodies for psychotherapy in the UK. This includes the British Association for Psychotherapy, BACP, the United Kingdom Council for Psychotherapy, UKCP, the British Psychological Society, BPS, and others. They all agreed that conversion therapy was unethical, ineffective, and potentially harmful, and not to be practiced. Conversion therapy was originally defined as the aim to change a person's sexual orientation. In 2017, this was updated to include gender identity. In other words, therapists and healthcare professionals are not to attempt to coercively change either a person's sexual orientation or gender identity. Most recently, UKCP has withdrawn its signature of agreement from the MoU2. This has provoked understandable outrage from individual members of UKCP as well as affiliated training organizations who were not consulted on the decision and who are strongly opposed to conversion therapies. It seems to me that those so understandably outraged do not understand UKCP's reasons for withdrawing their agreement to the MoU2. UKCP has clearly and repeatedly stated that it opposes conversion therapies. However, because the MoU2 includes children and because UKCP feels the wording of the agreement is not clear enough, it cannot agree to it as it stands. To me, and I imagine for UKCP, the question that hasn't clearly enough been answered is what exactly constitutes conversion therapy? The idea of exploratory therapy has come under fire by trans activists and their allies as merely a cover for conversion therapy. Anything other than wholehearted affirmation and confirmation of a child's declared gender identity has been unacceptable. Now let's situate this within the context of the findings of the Cass Review. The Cass Review has identified that GIDS has proceeded on the assumption that a child's subjective report of their transgender must be accepted as true. Then, without sufficient evidence for effectiveness or full understanding of potential harm, has gone on to facilitate gender transition, recommending social transitioning, puberty blockers, and cross-sex hormones. I want to read directly a statement made by UKCP that fully explains its view on conversion therapy and exploratory therapy. Before I do, I think it's interesting to note that this view was expressed after a case was brought against UKCP and won by a psychotherapy trainee named James Esses, who had been expelled from a UKCP member training organization because he had expressed gender-critical views while on his course. This statement by UKCP was published on November 2nd, 2023. It's a bit long, but I think it's necessary to read it all, as the backlash against UKCP seems to not truly understand its position. And I quote, "Following recent case law and the publication of the interim Cass review report, the UKCP Council for Psychotherapy is today issuing a statement on the law regarding gender-critical views and its implications for the practice of psychotherapy and psychotherapeutic counseling. This statement is also being made to highlight the fact that exploratory therapy must not be conflated with conversion therapy. Case law has confirmed that gender-critical beliefs, which include the belief that sex is biological and immutable, people cannot change their sex, and sex is distinct from gender identity, are protected under the Equality Act of 2010. Individuals who hold such beliefs must therefore not be discriminated against. Psychotherapists and psychotherapeutic counselors who hold such views are likely to believe that the clinically most appropriate approach to working therapeutically with individuals who present with gender dysphoria, particularly children and young people, is exploratory therapy rather than medicalized interventions such as puberty blockers, cross-sex hormones, or reassignment surgery. Such therapy explores the presenting issues through open-ended discussion and is conducted without any preconceptions or pre-decided theoretical framework regarding the person's gender identity. An important aspect of exploratory therapy is the ability to explore the fullest range of issues that may contribute to the person seeking help. Within the interim Cass review report, the exploratory approach is described as therapeutic approaches that acknowledge the young person's subjective gender experience, whilst also engaging in an open, curious, non-directive exploration of the meaning of a range of experiences that may connect to gender and broad self-identity. It goes on. Psychotherapists and psychotherapeutic counselors are free to conduct their professional practice in this way if fully consonant with the high standards set out by UKCP's Code of Ethics and Professional Practice. Working within the code underpins and informs best clinical practice. The exploratory approach can, of course, be taken whether or not the practitioner has sympathy with gender-critical views, with effective UKCP practitioners not allowing their own personal views to impede or bias an open, genuinely exploratory approach. Exploratory therapy should not in any circumstances be confused with conversion therapy, which seeks to change or deny a person's sexual orientation and/or gender identity. Conversion therapy, as so defined, is harmful and must not be practiced. The UKCP also accepts that the treatment of gender dysphoria is a complex matter, that psychotherapists and psychotherapeutic counselors may hold differing views on what approach is in the best interest of their clients, and that these views and practices and their associated professional diversities should also be respected, assuming, again, that they are consistent with the UKCP's Code of Ethics and Professional Practice. This is in line with the UKCP's values as an inclusive and pluralistic organization, embracing a variety of modalities and approaches to psychotherapeutic practice. End quote. I can't find where UKCP specifically and explicitly states that its reasons for not agreeing with MoU2 is because the agreement doesn't clearly distinguish between conversion therapy and exploratory therapy, and that it also doesn't clearly allow for exploratory therapy. But I think this is a fair guess as to why it won't agree. If instead of a knee-jerk reaction to UKCP's decision, assuming that it's motivated by some kind of transphobia and an endorsement of conversion therapy, if instead of that, people would read its explanation and think about it, maybe it could be seen as a wise, compassionate, and ethical decision. I agree with it, and if the language of the MoU2 could be modified with the clarifications that I've suggested, and which I believe UKCP wants to see, then I think UKCP would sign it. I'm reminded of the film with Henry Fonda, 12 Angry Men, about a jury intent on convicting an innocent man for murder, except for the lone voice of a single jurist who has doubts, and against strong protests, manages to persuade the jury to deliver a not guilty verdict. UKCP certainly is a lone voice in that collective professional jury. So now let's talk about exploratory therapy. The best resource I've found for learning about an exploratory approach is Therapy First. It started out being called Gender Exploratory Therapy Association, but has changed its name to Therapy First. It's a nonprofit professional association of over 300 mental health providers worldwide who view psychotherapy as the appropriate first-line treatment for gender dysphoria. They've published a downloadable guide called A Clinical Guide for Therapists Working with Gender-Questioning Youth. It's quite comprehensive and gives therapists a thoughtful, comprehensive, ethical, and effective way to engage in exploratory therapy with gender-questioning youth. This is their mission statement. Quote, "We aim to support psychotherapists working with gender dysphoric children, adolescents, and young adults in providing high-quality, evidence-based mental health care and to offer public education on mental health and psychotherapy." End quote. The guideline identifies what exploratory therapy is and is not. What is it? What follows is an abbreviated quote straight from the guidelines. Quote, "It is open to a range of outcomes. Exploratory therapy does not have a fixed outcome such as identification with natal sex as its goal. Instead, it is a patient-centered process which aims to explore, understand, and address the multiple intersecting factors generating distress in the young person's life. It understands that gender dysphoria emerges in a context. Gender-related distress, just like any other form of distress, occurs in a context. It cannot be understood without exploring the developmental, familial, relational, and social context within which it occurs. Gender dysphoria or gendered experience is but one aspect of the complex tapestry of each unique human life. It is developmentally informed. Gender dysphoria in young people is invariably embedded in larger developmental processes and struggles, including separation, individuation, and identity formation. Trans identification can be recruited to manage crucial developmental challenges and conflicts. It considers and addresses comorbid conditions. Comorbidities such as ASD, ADHD, social anxiety, depression, suicidality, and eating disorders are common in young people with gender dysphoria, and good clinical care includes a comprehensive exploration of how these conditions intersect with the young person's gender. It acknowledges the complex interplay of sexual development and gender identity. Sexual identity, which includes sexual orientation and gender identity development, influence each other, but represent separate aspects of adolescent development. Adolescents may experience struggles in either or both areas. It maintains an evidence-based approach to suicidality. It is often claimed that gender-questioning young people are at extreme risk of suicide. The data instead suggests that the risk in this cohort is similar to the suicide rate in young people experiencing a range of mental health issues. It promotes true informed consent. True informed consent is not possible without adequate self-awareness, including an appreciation of unconscious motivations, hopes, and fears. Further, informed consent requires honest and accurate discussion of the current state of outcome research and careful consideration of risks and benefits of transitioning. And what is it not? What is exploratory therapy not? Again, quoting from the guidelines, it is not conversion therapy. Conversion therapy is traditionally understood as an approach to treating same-sex attracted individuals which aims to produce a heterosexual orientation. There is considerable debate about whether this notion is applicable to gender identity. Nevertheless, attempts to force a normative gender identification and expression have no place in healthcare. Gender exploratory therapy does not aim for any fixed outcome in regard to how one experiences or expresses their gender. A normative cisgender identification is not its goal. Rather, it seeks to understand and ameliorate gender-related distress non-invasively, while respecting an individual's freedom to express themselves freely and authentically. It does not assume that trans identification is universally adaptive. A trans identity can allow some people to flourish, providing greater freedom, autonomy, and a sense of authenticity. However, for others, it can be embraced as a solution to psychological pain, ultimately failing to provide the solution that was hoped for. Therapists aim to help clients explore the sources of pain and distress in a wide-ranging way so that the client can become clearer about the function of a trans identity for them. Exploratory therapy seeks to help young people determine for themselves whether trans identification is adaptive or whether it's a response to pain, trauma, or other issues. It's essential that clinicians are mindful that patients may not always be conscious of the range of factors leading to their desire to transition. It does not assume that gender-affirming interventions are universally helpful. Although the affirmative approach is often presented as the gold standard treatment for gender dysphoria, there's no robust evidence to justify this assertion. It does not encourage the obfuscation of biological facts. Some young and vulnerable people believe that they can fully change sex and that medical and surgical treatment will transform them entirely into the desired sex. Exploration of the hoped-for benefits of transition should occur in tandem with an age-appropriate discussion of the reality of biological sex. Additionally, biological realities need to be disentangled from culturally constructed gender role stereotypes. In addition to a clear statement about what exploratory therapy is and isn't, the guidelines provide a robust set of areas for inquiry. I highly recommend you check it out if you are interested. I'll provide a link below in the description. The more I've thought about it, the more gender-affirming care itself seems like a form of conversion therapy. It prematurely determines a desired outcome. There's an assumption from the outset that the best outcome should be solely determined by the client's subjective experience. Without due exploration and in the absence of adequate evidence, a path is decided upon and taken. It is questionable to what degree children are able to give informed consent to this path. To what degree can they have realistic expectations about the results in terms of it resolving their distress and in terms of potential irreversible medical consequences? I'm grateful for the CAS review and for UKCP's decision to not place its signature on the MoU2. I'm hopeful that this may bring some needed reforms to the practice of gender medicine, particularly with children. I'm hopeful that exploratory therapy will become the norm and that the opposition to conversion therapy will continue to restrain therapists from imposing their own beliefs, either way, on clients. Psychotherapists continually work with clients who are facing major life decisions. Clients ask themselves and the therapist, should I get married or divorced? Should I take or quit this job? Should I change careers? Should I move to another country? Should I enroll in a degree program or a course of study? Should I contact my long-lost birth mother? Should I have or adopt a child? Should I get a vasectomy? Should I blow the whistle on my employer? The list goes on. A good therapist does not offer an answer. A good therapist helps their client to assess the costs and benefits of their choices. Either way, if a client seems poised to make a hasty, monumental life decision, one that may have profound costs, it's the therapist's job to help them slow down and reflect. It isn't the therapist's job to talk them out of it, but it is the therapist's job to help them find a path that they can be relatively sure will result in the least regret and the most benefit. This requires self-understanding and a realistic assessment of one's situation and the likely outcomes of one's choices. If we adhere to an ethic that suggests such a rule for therapists of adults, why would we not hold the same ethic? Would we not hold the same ethic for children? Especially when we understand that children are in a challenging developmental phase of life, marked by more impulsiveness and general uncertainty about their identity. They need adults to help them through this, not simply unthinking affirmation. Thanks for staying with me to the end. I've tried to make this as short as possible, but there is just too much to say. As it is, I've merely scratched the surface, but this is all for now. If you like this video, please give it a like, subscribe to my channel, click the bell for notifications, leave me a comment, and share it with a friend. If you think I've gotten anything wrong or you have a different opinion, please feel free to leave a comment to that effect. Until next time, take care of yourself and each other. Bye for now.